Okay there, so I'm unmuted. It looks like we have 10 people. I was hoping for a few more, so I'm not sure what's happened. Maybe turn on your screen for a moment. We can see who's here. So I see Wade and Cassie and Sarah and Emily and Claire and Eric and Carissa is just coming into focus there. Hi. And Kelly and Anna and Kaylee. And Broder's just signing in there. Howdy, howdy. Okay, we are going to get started for those of you who are here. I am going to be doing most of the talking this time. We'll hear talking from you some of the other times. I'm also recording this. I'm recording it to my computer, and then I'm going to figure out how I can put it up on YouTube or something. There is a cloud recording option, but in talking with let's see, when talking with folks at the library, we don't have a lot of storage space, so we won't be able to do the cloud recording option, but I am recording it because this is one of the more important, and I like to think more interesting topics of the semester. So I'm gonna go ahead and share my screen. Let's see, starting with the syllabus. Okay, so you should be able to see the syllabus here, and I can see some of you on a panel on the side. So I've made just a few corrections, a few changes as we go along, so I want you to be clear as to what we're doing. So today is Thursday, March 17, and we are going to be getting into clinical epidemiology. Okay. The assignment for clinical epidemiology isn't going to be due till March 31. We won't be able to get through this topic today, so there'll be some to finish up on Tuesday, and then the assignment would be due the week after that. Okay, so that will take us up through the next week and a half or so, and then next week on March 24, we'll finish up with clinical epidemiology, and then we'll get into some infectious disease epidemiology, looking at vaccine preventable diseases, herd immunity, and some related topics there. So that's what's happening for the time being. For assignment 6, the clinical epidemiology one, I have it listed on Moodle. You can do it either individually, or if you want to do it in cooperation with a partner, that's also fine. So that one, you can do a partner if you want, individually if it's easier, if that's what you'd prefer. We won't actually get to the content for this assignment. It's dealing with blood pressure. We won't get to that until next Tuesday, but you're welcome to look at it and get started if you wish, but it will make more sense after we've talked about it a bit more. So that's the syllabus. I want to look at with you a very relevant and current paper. This is an epidemiology class, and just in the past couple days or so, a paper came out from Italy looking at who is getting sick with coronavirus, who's dying, what are some of their underlying health conditions. I could not find an English translation of this paper, so I copied and pasted paragraphs into Google Translate, and it came out with a pretty reasonable translation. And when I read it, it actually made me feel better, at least on an individual level, because it clearly outlines who is most at risk for getting the disease and who is dying, and what underlying conditions they have. So I just want to look at this with you. I saw it referenced in the media, and I've, as I say, found the original paper. So this is just as of 2 days ago, looking at Italy and the characteristics of 2,003 deceased and positive COVID-19 patients in Italy. So this is getting into descriptive epidemiology, like basically the person, place, time, those type of factors. Just this is not peer reviewed. There's not time to send it to reviewers. It's basically just saying these are who's getting the disease and these are their characteristics. So first part isn't terribly interesting for us. It's just going through the various regions of Italy, showing the numbers of people infected. And Lombardy, that's where Milan is, that's been the center of the outbreak so far. But then we get into the demographics. Who's getting sick? The average age of deceased and positive patients is 79.5. And yeah, the median age for those who died was 80.5, and the median age for those who were infected is 63. You're all seeing my screen, I assume? Can I see some nods? Yeah, okay, good, good. So here we go. So these are the people who were diagnosed in green, and so you can see the median age is somewhat over 60. That means half are older than 63 or so, half are younger than 63. But then the deaths, the median death is 81, meaning half are older than 81 and half are less than 81. So this is primarily a disease of older adults, not exclusively, but primarily. Then if we go look here on figure 2, this is looking at the number of deaths by age group. This is deaths. So we've got men and we've got women, and we've got, so Donne is women, and Uomini is men, and tutti is everyone, or all. And so you can see the deaths, the age group out in Italy, out of their, what was it, 2003 people, only 5 are between 30 and 39. Only 12 are between 40 and 49. Only 56 are between 50 and 59. It's not until you get to the 70, 80 year age group is where the numbers really start to pick up. Okay, so that's interesting in and of itself. Not terribly surprising, because if we were to look at seasonal flu, I should have seen if I could find those data, we'd see something similar. Most of the people that are being affected seriously, most of the people that are dying are older adults. This is where it became even more interesting to me. So this table here shows of the people who died with COVID-19 infections, how many of them had these other conditions. So a third of them, 33%, had ischemic heart disease. A quarter had atrial fibrillation. 10% had had a stroke. 3/4 had hypertension. Over a third, 35%, had diabetes. 20% had cancer. And this reminded me of when we talked about costs here. The number of people who died of the 2003 who had, sorry, actually this isn't for 2003, this is 355. This figure was obtained for 355. So this isn't all of the patients, but nevertheless, it's a good sampling of them. Only 3 of 355 didn't have some of these other conditions. 48% of them had 3 or more of these other pathologies, these other conditions. So who are we talking about? Who is dying of coronavirus? Old people above 70 years old, a lot of them in their 70s and 80s, who have multiple other health conditions. Okay, and I'll be honest, when I look at this and when I see this, I'm thinking, okay, is it really necessary to be closing elementary schools? Is it really necessary to be closing college? Because at least based on the Italian experience, people in those age groups aren't dying, certainly. Now, maybe from a perspective of stopping the spread, well, if we're not meeting with each other, we're not going to stop the spread. But to me, it was very revealing that this is a disease of sick old people. And it's basically putting them over the edge. Because of these other underlying health conditions, they're unable to throw off the virus and they die. Okay, this was another one interesting, and I hadn't seen data like these yet. So this is looking at the most commonly observed symptoms prior to hospitalization in the deceased patients. Dyspnea and fever are the most common symptoms. Less common are cough, diarrhea, and Hemoptysis? Any people in medical terminology class? What's hemoptysis? Anyone? That is spitting of blood. Okay, spitting blood. So that's a common, or that's one of the symptoms they noticed. Dyspnea, this is disrupted breathing. So you think of apnea, sleep apnea. Dyspnea is disrupted breathing. Eupnea is good breathing. So the vast majority or the most common symptoms are breathing abnormalities, 74%, and fever. The cough is only less than half the patients who die had the cough. And notice what it says here, that 5.2% of people had no symptoms at the time that they were hospitalized, asymptomatic. Respiratory failure was the most common complication, acute kidney injury, heart myocardial injury. They mentioned the treatments that they use. Antibiotic treatment, terapia antibiotica, 83%, steroids and 27%, and antiretroviral, or antiviral, sorry, treatment in 52%. This here, I didn't get these translated, but you can see that for positive patients, the median times from the onset of symptoms to death was 8 days. Deceaso here, so we see deceased. So when the symptoms appear, the appearance of the symptoms till death, 8 days. From the onset of symptoms till hospitalization, you can see ospedale, recovery in the hospital, 4 days. Time of hospitalization to death was 1 day longer in those who were transferred to intensive care. So we have down here intensive care, 5 days from hospitalization to death, no intensive care, 4 days hospitalization to death. So relatively fast acting condition. And the last thing in this short paper, deaths under the age of 50. There have been a total of 17. Under the age of 50, and particularly 5 of these were less than 40. They were all male, all between ages of 31 and 39, and all had serious pre-existing problems, heart problems, kidney problems, psychiatric pathologies, diabetes, and obesity. Okay, so for me seeing that, for you seeing that, us as individuals, even me who's slightly over 50, our risk is really quite low of having serious health problems. Our risk for my parents who are in their late 70s, your grandparents who are probably also in their 70s into their 80s, those are the population that we have to be worried about. Be careful that they don't get exposed to. But it's relatively uncommon for serious complications or for deaths, apparently, in people under the age of 50. And those who did all had other serious had serious problems. I saw something, a guy in his 40s died in the UK, in England, and he had motor neuron disease. Okay, you know, other serious health condition. So this paper is up on Moodle. As I say, this is Google Translate, but it seemed to make pretty much sense to me. Feel free to look at it further, send it to any of your friends if you're sharing information, but this was the best sort of description of who's being affected. And I think what was also just drawing attention and reminding you, it's mostly people who have multiple other conditions, sick, elderly people. Okay, so I'm going to stop sharing that. And we'll get on with our content. There we go. So our topic today is clinical epidemiology, the epidemiological basis of disease. This is where we get down, where we get serious. How does epidemiology inform clinical practice? I know many of you are planning to be clinicians, physical therapists, PAs, PTs, that's physical therapists, occupational therapists, and others. And it's not uncommon for people to say, well, public health, that's all fine and good. Epidemiology, that's for public health, community health people. But what about me? I'm a clinician. I want to be a clinician. And my goal today is to convince you that if you're a clinician, you in fact depend on public health. You depend on epidemiology to inform your clinical practice. So here goes. Oh, as a reminder, assignment number 5, the salmonella assignment, get that done today or soon if you haven't. The assignment 7 we talked about, oh, and I forgot to change this. This is due March 31. So Moodle is always correct. It says Moodle March 31, so that's the day that that's going to be due. We talked about the coronavirus epidemiology. So here goes. From a clinical perspective, and I'd ask for you to unmute yourself. From a clinical perspective, how do we know what's normal or what is healthy? How do we know what is normal or what is healthy when we're talking from a clinical perspective? So you're a clinician, you're a physician assistant, and someone comes in and they have certain presentation. How do you know whether they're healthy or whether they're not?
Is it just based on guidelines that come from past research?
Guidelines that come from past research, yeah, that's that can certainly be part of it. Other ideas, that's certainly part of it, definitely. And what we're going to be talking about is what is that research and how do we get those guidelines? There might also be, and if it's an infectious disease, that's pretty easy. You can test for a virus, you can test for a bacteria, for a protozoa. Maybe a person has malaria and you can do a blood smear and actually see the protozoans. So for infectious diseases, there's usually some sort of a biological agent which can be tested for, identified, and that's pretty straightforward. However, when we're talking about chronic diseases, and you know that chronic diseases are the big ones, the ones that affect more people than any others, BMI. So do any of you know off the top of your head what BMI range is considered healthy? Carissa, do you know about BMI? What's a healthy BMI? Anyone?
Like 18 to 20 or something like that?
Yeah, 18 to 24, 25 or over is considered overweight. 18 would be sort of the lower side. 25, above 25, above 24, 25 is considered unhealthy. But the point is we all have a BMI, we all have a waist, we all have a weight. And so there's this continuum. At what point does it become unhealthy? If you test positive for HIV, okay, that's unambiguous, it's unhealthy. But blood pressure, where does 120/80 come from? And how do we know that a person with a blood pressure of 160/100, okay, that we got to do something about that? Blood sugar, every cell in our body needs blood sugar. So how do we, on this continuum of blood sugar, suddenly say, this point is too high, or this point is too high, or this point is too high? So it becomes a lot more difficult than with infectious diseases. So we're going to take a few minutes here. I'm going to assign some things for you to look up. So imagine this person, Mrs. Smith, comes in and you're a physician, you're a physician assistant, you're a nurse practitioner. We've talked about BMI already, and we know that her BMI is a little bit too high. We've talked a little bit about blood pressure, and most of you know about 120/80. So the blood pressure is a little bit high. How about fasting plasma glucose? Do any of you know these off the top of your head? If not, I'll ask maybe Carissa, can you look up fasting plasma glucose and find out if 140 is too high? Maybe Emily, can you look up hemoglobin A1C? Is 7% too high, too low? Wade, can you look up HDL cholesterol? Is 65 milligrams per deciliter, is that a good value or a bad value? I see Cassie there. How about LDL cholesterol? Is this a healthy value or not? Anna, triglycerides, 150 milligrams per deciliter, whether that's too high or whether that's too low. Broder, hemoglobin, 8.5 grams per deciliter. Is that a healthy level? And I see Palmer there. Uric acid, 5.5 milligrams per deciliter. Those that I've assigned something to, do a bit of quick research and come back, and we're going to determine whether which of these areas Mrs. Smith is unhealthy or whether she's fine. Okay, so we'll take a couple minutes. When you start getting values, just shout them out.
For the fasting glucose, you want it to be between 70 and 100.
Okay, for fasting glucose, so I'm just going to write this in here so I'll say 70 to 100. Okay. Okay, 70 to 100, so we would say that her glucose is too high. Okay, how about hemoglobin A1C?
So from Mayo Clinic, it says that for someone who doesn't have diabetes, normal level is below 5.7%.
Yep, less.
And for those with diabetes, 7% or less is a common treatment target.
Okay, so less than 5.7%. Less than 5.7% is considered healthy. 5.7 to 6.4 is considered
Pre-diabetes.
Pre-diabetes, and then
6.5% or higher means you have diabetes.
Okay, so on this basis as well, so we've looked at fasting plasma glucose, and it's higher than it should be. 2 tests, I believe, over 125 is considered diabetes. She's got a hemoglobin A1C. We haven't talked about that. Some of you are familiar with it. It's a totally different way of measuring blood glucose. So by both of those criteria, we would say that she has diabetes. How about LDL cholesterol?
So range was like 40 to 59.
Okay, sorry, HDL cholesterol. Is that, Wade, you said HDL 40 to 59?
Yeah.
40 to 59. But HDL is the so-called good cholesterol, right? So do we say that she has a problem if it's higher than 59? That's the question.
It said it could be it's normal if it's a little bit higher than that, but having it under 40 increases your risk of developing heart disease.
Okay, under 40 is increasing your risk. So HDL is the good cholesterol. The fact is her HDL cholesterol is a little bit on the high side, but that's not bad. That's not something that we need to worry about or that you as a clinician would need to treat. How about LDL cholesterol?
LDL should be less than 100.
Okay, so you as a clinician would say, okay, LDL cholesterol is too high. LDL is the bad cholesterol. If it stayed at that level, you might need to think about cholesterol lowering drug. How about triglycerides, Carissa?
I did triglycerides and
Oh, sorry, yeah.
Normal, it's okay. Normal is below 150 milligrams per deciliter, but borderline high is 150 to 199. So.
Okay, so she's at the low end of borderline high. Probably not be putting on some lipid-lowering medications, but keeping an eye on it, yeah. Let's see. And hemoglobin, who was looking at that?
I was, and for women, the normal range is 12 to 15.5.
12 to 15.5. Okay, so her hemoglobin is low. Might be concerned about possible anemia. And let's see, Palmer, uric acid.
Yeah, 2.5 to 7.5.
Is considered normal?
Yeah.
7.5. So we would say she doesn't have, hers is right in the normal range. Okay, and so you as a clinician, you would see lab measurements like this all the time. And so, as was mentioned earlier, there are references, there are diagnostic standards which specify, and all these numbers like fasting plasma, 70 to 100, hemoglobin A1C, less than 5.7%, all of those numbers are coming from population studies, from epidemiology, from public health. There is nothing inherent or innate or sort of internal that tells us that a blood glucose level of 140 is bad or unhealthy. And you as a clinician would never know that unless you were informed by public health, by epidemiology. So we're going to look in more details. So the next slide. What is abnormal? What is normal? What constitutes a diseased condition when there is no biological agent? So we're talking about chronic diseases. Some people might say, well, look at average. If your clinical value is above or below the population average, then maybe there's a problem. Do you like that definition? Just take the average of the population, and that would inform us as to whether or not you have a condition that's, you've got too much. Okay, we'll come back to.
Maybe it's like a good baseline, but not like perfect for everyone.
Okay. So if it's above average or below average, if above is bad or if below is bad, it might be a place to start. Another thing that we would want to look at is the relationship between a clinical measure and a disease outcome. That's narrowing it down a little bit more. Do people who have blood glucose above a certain level have higher rates of this? Do people with a BMI above a certain level, are they more likely to get a certain pathology, a certain disease? And importantly, I would add, can we treat it? If we identify something, even if there is an association with a disease outcome, is there anything we can do about it? So let's look at some examples. So this is considering the idea that, well, we would say that normal or healthy is merely the average. But what happens if the average creeps up over time? This is an intriguing figure that I found. So this is looking at BMI levels for 18-year-old American men, WPC, that's West Point College, or West Point Cadets, military school in New York. SC, that's the Citadel Military Academy. And so we can see that in 1850 to 1879, the average BMI of cadets at West Point was somewhere just under 20. And in the Citadel, in that same period, it was slightly over 20. And then we come to the US, 100 years later or so, and the average BMI is up for 18-year-old men, whites, is up over 22. And by the 1980s, it's up over 24. So we have this BMI, I mean, we're getting bigger. We're taller, we're heavier. And so you've got this moving value of BMI that's been creeping up over the years. And so to simply say, well, unhealthy is over the average, or if you're higher than the average, that's a problem if we've got a value that is been climbing up over time. Here's another example. This is looking from N. Haynes and nutrition students. We've talked about this a lot. So this is looking at N. Haynes, or they used to call it N. Hess, back in the early 1960s and up through the early 2000s. And you can see that for males, 20 to 74, back in 1962, it was 25. In early 1970s, 25.1, 25.7, 25.6, 28.6, 26.8, sorry, and 27.9. We're getting heavier. Same thing we see with women, even looking at younger women in their 20s. In the 1960s, the average BMI was 22, then it went up to 23, and then it was 23, and then it's 24, and now it's 26. And so we look here, looking at women, say, if you can follow along my cursor, 60 to 74. The average BMI of women from 60 to 74 is 29.2. That's high in the obese category, or high in the overweight category, almost to the obese category. And yet that's the average. So there would be some problems to say, well, if you're above average, you're too high, because it's also possible that everyone could be too fat, at least if we're interested in health outcomes. So that's a challenge, a difficulty of merely looking at averages, because averages change. So this is looking at, yeah, and then this is more recently. So this is NHANES up to 2016, and you can see that there's groups here, Mexican American women, the BMI is in the obese category. The average is obese. So you've got these various categories you can see as they go up. So then let's look at the issue of association with disease. So this figure shows systolic blood pressure. That's the blood pressure when the heart is contracting. And it says what the upper number on your blood pressure measurement, the usual systolic pressure, and the stroke mortality. Okay, and so you can see that as systolic blood pressure goes up at all age groups, so we see this is mostly older adults, 50 to 59, 60 to 69, 70 to 79, and so forth. As blood pressure goes up, the risk of stroke mortality goes up dramatically. And you'll notice this is a base 2 logarithmic scale. And so we go 1, 2, 4, 8, 16, and so forth. And so a person aged 50 to 59, my age category, if we're comparing a systolic blood pressure of 180 versus 120, a person with 180, if we read over to the y-axis, has somewhere between 8 and 16 times greater risk of a stroke versus a person who has 120. And we see that for all the age groups, even older people in their 80s, their blood pressure is a lot higher to begin with. The vasculature is less elastic. So even at a blood pressure of 120, their stroke risk is much, much higher than for a person in their 50s. But still, as blood pressure goes up, the risk of stroke, more than doubles again on this logarithmic scale here. Does that make sense? Okay, so we're seeing a relationship between a clinical measure, in this case blood pressure, and an outcome, which is stroke mortality. So that's for systolic blood pressure. We see the same thing for the diastolic blood pressure, the lower number, the number when the heart is at rest, and still there's a massive change in stroke risk mortality having a diastolic blood pressure, say in the 70s to the 80s, versus up over 100, they're 16, 20 times more risk compared to a person with a lower blood pressure. Okay, so what we're seeing here then is as blood pressure goes up, risk for stroke goes up. Starting to make associations between a clinical value, which is a continuum, and a disease outcome. I'll put this question out here. Is age a risk factor for cancer? This is looking at percent of new cancers by age group, all sites. Most cancers you can see are between 55 and 75. Close to half of all cancers age 55 to 75. Can we treat or prevent advanced age? Not really. So we would say, is age a disease? Probably not. Probably not. Maybe at some point in the future we can reverse aging, but at this point we can. So even though we've identified a risk factor here for cancer, which is age, I'm not at least going to say that age is a disease, because we can't treat it. We can't do anything about it. we'll look at an example in a little bit where, in a sense, we have created a disease. We found a relationship between a clinical factor and a disease outcome. And oh, we discovered a drug that we can do something about it. And so we have created, in fact, a new disease. And that's this disease here. Coronary heart disease increases with higher LDL cholesterol, the low density lipoprotein cholesterol. So you can see on this graph here, it doesn't have numbered axes, but they're giving those relationship. All these acronyms here, these numbers, these are various studies. So the WASCOPS, that was a study, the lipid study, the CARE study, the PROVE IT study, the TIMI 22 study. These studies all showed a relationship between LDL cholesterol and relative risk of coronary heart disease. So as LDL cholesterol increases, your risk of heart disease also increases. Okay, and we know this, this has been known for a while. So what if there is a drug that can lower LDL cholesterol? Turns out there are, and you've probably heard of them. They advertise on your TV shows a lot. The class of drugs called statins. They're a class of drugs that lowers the level of blood cholesterol, I'm just reading here, by reducing production of cholesterol by the liver. Remember, all of our bodies, all animals, all mammals at least, and I think other animals, but certainly all mammals, produce cholesterol in the liver. It's used as a precursor for hormones in the body. It's necessary. Okay, so if we can reduce the liver's production of cholesterol, maybe we can lower our blood cholesterol level, and maybe that will reduce coronary heart disease. Okay, so statins block an enzyme in the liver that's responsible for making cholesterol. The enzyme is called hydroxymethylglutaryl coenzyme A reductase. Scientifically, statins are these inhibitors of this previous enzyme. Okay, the enzyme mixed cholesterol is HMG-CoA reductase, and so if we inhibit that enzyme, or if statins inhibit that enzyme, there's less cholesterol produced in the liver. And that is where we get to these names such as Lipitor, Mervicor, Altoprev, Prevacol, Zocor, Crestor, and so forth. You'll notice these are the various names. These are the generic names: atorvastatin, fluvastatin, lovastatin, pravastatin, rosuvastatin, simvastatin, and pitavastatin. These are all the chemical names of the statin molecules that each of these companies have manufactured, have synthesized as cholesterol-reducing drugs. Okay, and many, many people, probably some of your parents, probably many of your grandparents, are taking these drugs to reduce production of cholesterol in the liver. Those of you who are or have been in nutrition class, remember we've talked about the issue, does dietary cholesterol, eating eggs, cheese, milk, which do contain cholesterol, the extent to which those substances affect our blood cholesterol. And there is some evidence, pretty decent evidence, that dietary cholesterol isn't the most important determiner of what our blood cholesterol is, which is why the Dietary Guidelines Committee there a few years ago said cholesterol is no longer a nutrient of concern. And we talked about that a lot in nutrition class. Okay, so if we can lower LDL cholesterol, maybe we can reduce coronary heart disease. Okay, here we have information from some of these various studies showing that, and this is a systematic review, you can see the line for 1 down the middle. If it's to the left, that means that it favors statin therapy, and the overall value is somewhat to the left, meaning that when you take these studies together, this one here, for example, this PMSG study, the error bar crosses the line, so that particular study wasn't statistically significant. The PREDICT study wasn't statistically significant, but more of the studies are to the left of the bar than to the right of the bar, and so that tells us overall the relative risk for statins was 0.75, meaning that there was a 25% reduction in the outcomes here for coronary heart disease, mortality or non-fatal myocardial infarction. So this is the basis then for all these statin-lowering drugs, these statin drugs, these cholesterol-lowering drugs, because taking many studies together, it's shown that, yeah, people who take them have a lesser risk of coronary heart disease, mortality, or heart attack than people who don't. Okay, so this here, the last one I want to look at for this here is looking at the association between reduction in LDL cholesterol and incidence of stroke. And so you can see if the reduction in LDL cholesterol was 10%, there was a little reduction, maybe like instead of it being 1, it was down to 0.9. As we reduce cholesterol more, so if there's a 50% reduction in cholesterol, you can see here that leads, say for the Jupiter trial. So the Jupiter trial, 50% reduction in cholesterol. If you read that over to the y-axis, you can see it's almost a, say like 52% relative risk, or you could say about a 48% reduction in risk of stroke. Again, all these words here, these are just different clinical trials. You can see CABG there, those of you in medical terminology, coronary artery bypass grafting, CABG there. So we created a new disease, or the medical profession, the pharmaceutical profession created a new disease. And this disease is called hypercholesterolemia. Cholesterol, hyper, too high, cholesterol, anemia condition. So a condition of elevated cholesterol. 100 years ago, there wasn't hypercholesterolemia. 200 years ago, there wasn't hypercholesterolemia. There wasn't a way to measure it. There wasn't a way to treat it. There wasn't a knowledge of the association between elevated cholesterol and heart attack, death, cardiovascular disease. But by combining epidemiology, the ability to measure and detect cholesterol, and the ability to manufacture, to synthesize statin drugs, we have a new disease. Isn't that amazing? I like to think so. So we have a disease that simply did not exist previously through the use of pharmaceutical technology and epidemiology, basically. Because we could measure it, we saw the associations between high cholesterol and disease outcomes, and we could do something about it. Okay, does that make sense conceptually as to how a new disease was created? Okay, let's move on. BMI. What's our time at? Okay, so we got half an hour or so. BMI. We talked about this a little bit, and it was mentioned that normal BMI is 18 to 25, 18.5 to 25. Then we have our categories: overweight, class 1 obesity, class 2 obesity, class 3 obesity. And we asked the question, where did these numbers come from? What is it? How do we know that this is a normal and healthy BMI? Well, we start to look at data like these. This is for men. This is looking at 313,000 men over a period of time. You can see the link at the bottom if you want to look at it further. And you can see, okay, where is there the lowest risk of death? And for men, it looks like it's right around, you can see here the relative risk of death, they've drawn that line for 1. And that the lowest risk of death was at a BMI right about 26 or so. You see that? As the BMI increases, the risk of death increases. As the BMI decreases, the risk of death also increases. So for this group of men, compared to a BMI of 25, say on the line of 1 here, a BMI of about 20, they had about a 50 to 60% greater risk of death. Okay. Some of you who are relatively skinny might be thinking, okay, is this a problem? We'll come back to that. But you see then this U-shaped curve. So that in fact, a person whose BMI is at 20, here about 1.6, their risk of death is about the same as a person whose BMI is somewhere 37, 38. You can see if we were just to draw a line here across and then read down to the x-axis. Part of the reason is for the low BMI also having an elevated death rate. Often people who are old, they waste away, you get wasting syndrome, and so basically their skin and bones, and so they would also have a very low BMI, and so elderly people who are wasting away, or even people who die of other wasting conditions, infectious conditions. HIV was notorious. People became basically walking skeletons. Okay, so that does not mean on an individual basis that if your BMI is, say, 21, which is very possible for those of you in college who are relatively slim, that doesn't mean that necessarily you individually have an increased risk of death. It's just if we take all men of that BMI, they did have a more elevated risk than men whose BMI was around 26 or so. This is looking at it by different age groups, you can see, but still the lowest death rate, the lowest relative risk of death was somewhat under 1, for a BMI was right around 26. Here they're looking at it for smokers. Here they're looking at it for men who have never smoked. And interestingly here, this is the BMI at age 50. Here we see the lowest relative risk of death was at a BMI of about 24. Okay, and this now is looking at women, and you can see for women the number 25 sticks out loud and clear. The lowest risk of death for women is right at 25, and the lowest risk of women who had never smoked, you can see the healthiest BMI, or the lowest risk of death, was at around 22. Okay, so it's looking at population data like this, where some of these numbers sort of, in a sense, start to appear. 25 just starts to appear from the data. And yes, depending on whether it's males or females or smokers or non-smokers, it might change a little bit, but there's something about a BMI of 25 at the population level that is associated with less risk of death. Now, some of you might, again, be concerned on the upper end. A couple of years ago, there was a student in the class, and a football player, and his BMI was up over 30, I think 31 or 32. And he comes to me after class and says, should I be worried? What would you tell him? Should a Carroll College football player with a BMI of 32 be worried? And let me see here, sorry. Let's look at some numbers here. I'm going to stop the sharing, and I'm going to share my screen. Okay, so I'm going to pick up a BMI calculator. Let's see. Okay, so you imagine a guy who is 6 feet tall and 0 inches. How much might a Carroll College football player guy who is 6 feet tall, how much might he weigh? Anyone?
215.
Two what?
215.
215. Okay, very possible. Okay, BMI is 29. Okay, that's in the, and you can see that's in the overweight category. It would be very easy for a 6 foot football player even to have a weight of, say, 235. Oh, their BMI is 31, indicates that you're in the obese category for adults of your height. Okay, let me get back here. Oh, I'll stop sharing there, and I'll go back to here. Okay, so what do you think I should tell the football player who's got a BMI of, say, 32? What do you think, Wade?
I think not to be worried because I don't know, his situation is different from the average across like the population. Like his muscle mass is going to be different. He's not necessarily overweight compared to like some of the population.
Okay, what was crucial there is you said muscle mass. Hopefully a good part of the BMI of 32 of this football player is muscle mass. And you remember that BMI just takes into consideration weight and height, and whether that weight is belly fat or whether it's thigh muscle or biceps or just overall body musculature, the BMI doesn't make any distinction. So to look at BMI on an individual basis, it might be fine as a screening tool, but it is not good for diagnosing and saying, hey, this person, their BMI is 28, therefore they're unhealthy somehow, or even a BMI that's up over 30. Okay, because it's just looking at the mass of the body, the weight of the body, not the components of it, and whether it's belly fat, visceral fat, fat around the organs, or whether it's really big, thigh muscles and biceps and triceps and calves and all that type of thing. Okay, so don't get too hung up on BMI on an individual basis, but on a population basis, it is very beneficial. Let me see here, screen. Yeah, I wanted to do this one. Okay, so back to our, okay, I want you to look at this. And I want you to look at it. This is looking at BMI and diabetes. And take a look at it a little bit and see if you can make sense of it. These are the BMI categories on the top. I'll talk you through it a little bit. BMI category 1, BMI is less than 23. BMI category 2 is from 23.0 to 23.9 and so forth. These are the cases, the person years, the number of cases, and then we get into relative risks here. So, when does diabetes risk start to increase? At what BMI? Take a look at it, and when someone got it figured out and brave enough, jump right in.
Is it the BMI category 4?
Okay, tell me more.
Just looking at the case age adjusted for the cases, seems to jump from 3 to 4.
Okay, so the cases number is here, and then we've got the age adjusted relative risk.
Oh, okay.
Yeah. So what do we see here? They give people with BMI less than 23, they assign a value of 1. People whose BMI is 23 to 23.9, their relative risk of diabetes is still 1. The confidence interval here includes the value 1, so it's not statistically significant. 24 to 24.9, the relative risk is 1.6. So you could say, oh, it's 60% greater, but the confidence interval includes the number 1, so it's not significant. When we get here to BMI category 4, as Anna pointed out, the risk of diabetes is now 2.3. So it's 2.3 times that of people who have a BMI of less than 23. And importantly, our confidence interval does not include the number 1. So we would say it's statistically significant. So that people with a BMI higher than 25 or from 25 to 26.9 have 2.3 times the risk of diabetes of those people whose BMI is less than 23. And as we go up here, people whose BMI is between 33 and 35, well, actually we'll go up here. People whose BMI is 35 and greater, they have get this, 50 times greater risk of diabetes compared to people whose BMI is less than 23. 50 times, 50.7 times. And even when they do adjustments for various others, you can see in the bottom, the multivariate adjustments they control for cigarette smoking and cigarette status, yeah, and family history. It's still 30 to 40 times greater risk of diabetes. So, what would you tell someone, and you hear this sometimes in the media, oh, I can be fat and fit, I can be fat and healthy. What would you tell them, Hannah?
I would say that's an incorrect statement.
Could it be true on an individual basis?
Yes, I think that as far as like BMI I'm talking about with like the football player example, that muscle can be heavier, bone structure, all of that. However, in the case of actual, I would say, if adipose tissue is heavier than the actual muscle or bone density, then that would be the problem.
Yeah, so again, this is looking at all people in their sample, says 27,000, and this is for men, and this is for middle and older aged men. But taking them as a group, no, they're at vastly increased risk of disease, of diabetes, although, as we just heard from Hannah, and I would reiterate that, on an individual basis, they might be relatively healthy. And so the question is going to be, so a person who has a BMI over 35, is that muscle or is that fat? And if you're looking at men aged 40 to 75, in the vast majority of cases, it's going to be fat. Okay? So if it's a 25-year-old NFL player, maybe it's not, but if it's an average 45 or 50-year-old US male, that's fat, and they are at elevated risks. No ands, it's ifs or buts. On an individual level, some might, just like some smokers don't die of lung cancer or heart disease, and there are people who are obese who don't have diabetes. That is true, and there are skinny people who do get diabetes, but when taken as a group, as a whole, the data are very clear and it's consistent. But what I want to emphasize here is, in this slide, we looked at BMI. In this slide, we looked at diabetes. Sorry, my mistake here. In this slide, we were looking at relative risk of death. And we see, 25-ish. In this slide, we're looking at diabetes, and what do you know? That number 25 sort of emerges again, pops out. Let's move on. This is looking at cardiovascular disease risk factors in Hispanic and Latino adults. You can see the scale, normal weight, overweight, and then the class 1, 2, and 3. So normal weight, that's going to be a BMI of 18.5 to 24, overweight 25 to 30, and then we get our class 1, class 2, and class 3 obesity that we looked at. And so we look at hypertension. As BMI or as obesity goes up, hypertension goes up in both men and women, although it's stronger in men than in women, that relationship. As BMI goes up, diabetes risk increases. So here, class 3 obesity, and class 3, let me just go back here. Class 3, this is a BMI higher than 40. So we're looking here, people with a BMI higher than 40, 40% of them have diabetes among Hispanic men. LDL cholesterol. Okay, LDL cholesterol is the good cholesterol. Sorry, my mistake. LDL cholesterol is the bad cholesterol. High LDL cholesterol, you can see there isn't a big jump as we get into various classes of obesity. But compared to people who are normal weight, those who are overweight or have various classes of obesity, they do have higher prevalence of high LDL cholesterol. This is the one I was thinking of, low HDL cholesterol. HDL cholesterol is good, and the prevalence of low HDL cholesterol is lowest in people who are normal weight. Okay, so just be thinking carefully. People who have various classes of obesity have a higher prevalence of low HDL cholesterol, which is a bad thing. So there's more commonly to have the unhealthy outcome, I guess is what I would say. Triglycerides as well, you can see go up, not as consistently, there isn't that same dose response. And particularly in women, Hispanic women, obesity and triglycerides, there isn't a really strong relationship. Although the lowest prevalence of high triglycerides is in the normal weight individuals. Once we get into the various classes of obesity, there's not a lot of difference. And the last one I want to look at is C-reactive protein. Do any of you know what C-reactive protein is? Maybe you took Dr. Gretsch's cell biology or class. Any of you know about C-reactive protein? Please jump in if you do. No? Okay, C-reactive protein. It is a general inflammation, it's a marker of general inflammation level in the body and associated with many diseases. Okay, so for example, here I'll just talk through this. This is looking at levels of C-reactive protein and risk or predictive risk for cardiovascular disease. So if they give a value of C-reactive protein as being less than 1, the relative risk is 1. If the C-reactive protein is between 1 and 3, the relative risk is 49% greater, although you can see that's not statistically significant. The confidence interval includes 1, and they also give us the p-value, which is not less than 0.05. But here, C-reactive protein higher than 3, it's statistically significant, 78% greater hazard or risk for coronary heart disease, cardiovascular disease, compared to people with lower C-reactive protein. So if we go back here, people who are in these various categories of obesity, both men and women, have much higher C-reactive protein. And then from this slide here, C-reactive protein predicts cardiovascular disease. Okay. So far, so good. Anything that you want to go over? Okay, a little bit more here. Looks like we have about 10 minutes. Blood glucose. So we're going to now look at the issue of diabetes. Actually, just to review and to keep you up to date. So we've talked about BMI and where the number 25 comes from. We looked at that in terms of death, and we looked at it in the terms of diabetes. We looked at BMI, again, normal weight being BMI of 25, or say between 18.5 and 25. And we see for all these conditions, hypertension, diabetes, high LDL, low HDL, triglycerides, C-reactive protein, for most of them, with some exceptions, but we see a relationship that people who have these various classes of obesity are at greater risk. We talked about C-reactive protein. Let's talk about blood glucose, and that will probably take us to the end of our time together. So just as a review, type 1 diabetes is an autoimmune condition. The islet cells in the pancreas that produce insulin have been destroyed for some reason, and the person is not producing insulin. Type 2 diabetes is referred to as an insulin insensitivity. The islet cells in the pancreas are alive, they're producing insulin, but the body's cells are not receptive to it. They don't respond to it. About 95% of diabetes is type 2. When the American Diabetes Association, I think we talked about this earlier in class, when the ADA talks about diabetes, they lump them together, but 95% is type 2. The complications of diabetes are dramatic, they're devastating, they're debilitating. Cardiovascular disease, retinopathy, that's a condition of the retina leading to blindness. Diabetes is a major cause of blindness, and particularly as people get older. Kidney disease, also known as nephropathy. The blood vessels in the kidneys are affected by this continuous exposure to elevated glucose, and it leads to kidney disease. Most of the people who are going to kidney dialysis, it's related to diabetes. Not all, but most. Neuropathy, nerve condition leading to loss of, first of all, it might be tingling or numbness. It usually occurs in the feet first, but it can occur in the hands. And people get injured and they maybe don't feel it as well. They don't heal, and this leads to amputations. Hypertension, high blood pressure, and stroke are also associated with diabetes. Okay, so this is looking at the association. Oh, this is let me say here. This is looking at the association between blood glucose and various disease outcomes. This is another measure. This isn't fasting plasma glucose in milligrams per deciliter. This is fasting plasma glucose in millimoles per liter. You've all taken chemistry, just another way of measuring it. So you can see that as fasting plasma glucose increases, the risk for stroke increases. So a person who's fasting plasma glucose is, say, around 5.5 compared to a person who is 7.5, you can see they've got double or more the risk of stroke having that higher blood glucose. Total heart disease, total ischemic heart disease. This is loss of blood to the heart. Again, you can see a relationship as fasting plasma glucose goes up, the risk, the hazard ratio, the hazard risk for stroke goes up. The risk for cardiovascular death also goes up. Okay, and this is the one that I find the most dramatic, because it turns out that the retinas, the blood vessels at the back of your eye, they are the part of the body that is most sensitive to elevated blood glucose levels. Okay, so what we have here is a curve. This is looking at hemoglobin A1C, and this is percentages, and looking at the prevalence of retinopathy, the condition of damage to the blood vessels. This is done, they can, an optometrist, an ophthalmologist can look at the back of the eye. They'll actually take pictures of the back of the eye, and then they can be analyzed, and there are specific little occurrences where the blood vessels, you can see, start to leak out into the tissue. I don't think I have any pictures of that, no. But it's something that can be visually diagnosed as whether or not a person has retinopathy. And you can see, where does the prevalence of retinopathy really take off? It's right about here. And if you read that down to the x-axis, what number do you get? 5.7%. That's where that number 5.7% comes from when we're talking about hemoglobin A1C. Because that, in a sense, is the sentinel, the first place in the body where damage starts to show up. And so physicians, researchers, diabetologists, ophthalmologists looking at the data said, okay, if your hemoglobin A1C is above 5.7, it's starting to have a negative impact on the body. Okay, so these numbers, BMI of 25, hemoglobin A1C of 5.7 or percent, or 100 milligrams per deciliter. These numbers often just sort of emerge when they look at the data. Okay, so I find this intriguing and revealing that, right, you know, somewhere 5.7, it shoots up, and your prevalence of retinopathy shuts off or increases, and that's then what we use as the basis for a diagnosis of diabetes. Or pre-diabetes is 5.7 to 6.4. So, but that's when the damage really starts to emerge. Okay, here we go. This is looking at hemoglobin A1C and looking at those various endpoints: retinopathy that we talked about, nephropathy, kidney disease, neuropathy, the nerve disease, microalbuminuria. This is basically protein in the urine. And you can see here that this is looking at a BMI, at a hemoglobin A1C above 6, but you can see that it's retinopathy that takes off the quickest. The slope is the greatest. Nephropathy, damage to the kidneys, is second greatest. And so you can see that a person with a hemoglobin A1C of 10 has a, maybe about 6 times the risk of kidney disease, of nephropathy, compared to a person whose BMI, whose hemoglobin A1C is 6. Okay, so very, very strong relationship between hemoglobin A1C and particularly retinopathy and nephropathy, lesser but still substantial for neuropathy and microalbuminuria. Hard word to say there. Okay, so we're gonna look at, actually I've got more diabetes things. I think we're gonna stop here today then. Okay, it's 3:27. So I want to thank you for those of you who jumped in and answered some questions. I am recording this. Not that you have seen it, need to see it again, but particularly for those who haven't looked at it, and I'll send a note to them. I'll try to figure out, I'll probably upload it to YouTube so we can get a record of it. So what I would say then is finish up the salmonella assignment, and you don't, unless you want to, you don't really need to start looking at the assignment about blood pressure, because we've got quite a bit more to say on this topic, which will continue next Tuesday. So on that note, I'll stop the sharing there and I will wave goodbye to you. Any of you traveling over the weekend or heading home? No?
I'm going home today.
What's that?
I'm going home right after this.
Okay. Okay. Well, safe travels to those of you who are, and we hunker down and make the best of it. But I'm just impressed and grateful for the technology we have that makes this doable and relative. I'd never used Zoom before the past couple days, and it actually works really well. So I'm impressed, and I hope you are. And so I'll sign off, and let's check in then on Tuesday at 2:15, and we'll wrap up this fascinating topic and talk about the assignment and move on from there. So stay well, don't get bored, go outside, exercise. When I get home, I'm going walking with my wife, and once the trails clear up and it's not muddy, we'll start hiking. We're planning to do a hiking trip with some friends this summer in the Rocky Mountains, probably in Colorado, and need to get back in shape. So I stepped on the scale actually yesterday, and there's a few extra pounds, so it happened. So take care, and I will see you on next Tuesday. Bye.
Thank you.
Thank you.